Can you see my slides as well?
Okay.
Okay, that's fine. So, good evening, all of you. I would like to thank deeply my friend Costas and the rest of the organizing committee for this kind invitation to participate in this real fabulous meeting. So, the case I'm going to present is not something technically challenging, as it's very clinically interesting, I'm afraid. So, the journey of this patient started around 17 years ago. So, the patient presented with the cardiogenic shock back. I was consultant interventional cardiology at Daniel Hospital in Piraeus. And the patient proceeded with being in the state of cardiogenic shock due to acute anterior myocardial infarction. So the patient transferred to the CCU. I performed a primary PCI to a left main LAD in right coronary artery at the time, and the patient remained intubated for about 10 days and discharged the patient being well for about 8 years. 8 years later, the patient started having shortness of breath, mainly on the moderate exertion, and gradually he has been deteriorated and ended up as having pulmonary edema. So he was at the time 82 years old, and he rang me to tell me that the stent I have put in maybe has been degenerated. The most important thing that the patient had one single disease, just dyslipidemia, nothing else. He was not smoker, lifelong no smoker, not any other extracardiac issues till now. So once I saw the patients in 2015, the time the patient was 82 years old, you can see here that the patient have severe aortic stenosis, severe calcified aortic stenosis with severely impaired left ventricular ejection fraction. So at the time, the patient, the condition of the Transcatheter heart valve program in Greece was not very widespread, so it was not easy to get approval for these cases, which were considered as futile. The estimated ejection fraction was less 20%, and the patient considered that it could be futile to have an intervention on this patient. Profoundly, the patient declined from the cardiac surgeons. So you see here again intravascular evaluation of the same patient due to evaluate the mitral regurgitation as well. So you can see that the left ventricular ejection fraction is really compromised, dilated left ventricle, akinesis, and spontaneous contrast in the left ventricle. Finally, we got the approval after long-lasting discussion with the boards for the committee for the approval of the protocol of the valve, and the patient approved to receive the bioprosthetic valve by the TAVI. So we can see here, appreciate the severe calcification of the aortic valve in this. And finally, we ended up at the time to give to the patient, to offer to the patient 29 core valve device. That it was the time that's available, 29. The 34 was not available at the time. And the mean diameter was about 24. So in this first aortogram, you can appreciate the stents throughout his coronary arteries, and profoundly you can appreciate as well the severely impaired left ventricular ejection fraction that does not really exceed to 15%. Anyway, at the time, before doing the procedure, I do remember his wife saying to me, "Please, doctor, please save my husband, because he can't sleep during the night. He's always sitting in chair, and it's not possible to sleep even for 1 hour. So just to have 1 or 2 years with good quality of life." So we proceeded. To be honest, I was not very happy, and I was not very happy with the outcome of this procedure. So finally, we implanted the device, a 29-core valve device, and with very good outcome, no very good alignment. We didn't know enough for the alignment at the time. However, the patient had immediate symptoms relief, excellent transthyretin and clinical findings in terms of valve mechanics. But the left ventricular ejection fraction never improved, but the patient remained asymptomatic till today. Unfortunately, his spouse passed away 3 years ago, but he's still alive and he's sound and well, doing gardening and swimming at his own home at Salamina. The take-home message from these presentations, the clinical take-home message is that patients having no comorbidities, regardless of how old they are, they may have very good outcome if you treat the main condition that make the patient symptomatic. And this, despite the severe coronary artery disease and compromised left ventricular ejection fraction, TAVI seems worthy even in severely symptomatic patients on symptomatic and prognostic grounds. Thank you. I hope I was very brief.